Hi, I'm Julie Battel, and I'm a nurse midwife. And the title of my talk today is Death by a Thousand Paper Cuts. We're going to go on a little journey here, so stay with me. Jane got her first period at age 11, and she started cycling regularly in about 3 months' time. And she recalls her first period and periods as very heavy bleeding, um, painful, passing lots of clots, needing to use a hot water bottle, ibuprofen, and needing to use a Super Plus tampon and a maxi pad at the same time. She would often miss a couple of days of school during her cycle, and her mom took her to the pediatrician. And the pediatrician told her that it was normal for girls to feel pain. Really didn't offer her anything. She felt upset about it, but what did she know? And she went on and continued to sort of feel bad, have pain. And when she talked with her friends about it, they weren't having similar symptoms. So she was upset about it. Her mom took her to an adolescent gynecologist who was kind to her, but normalized her pain. Told her to practice mindfulness and possibly meditation if she was game for that, and offered her hormonal birth control, gave her a prescription for naproxen, and told her that this was what was going on with her for now. And she became increasingly distressed and just felt that nobody understood her. And fast forward to age 18, she's a freshman in college, has her first sexual intercourse experience, and remembers it to be exquisitely painful. When she talked to her friends about that, they all said, it always hurts the first time, no big deal. And within 3 to 6 months, she was starting to have diffuse pelvic pain and having symptoms of dysuria or pain with urination. So she went to her college health services, and they ruled out a UTI. And when she told them about her other symptoms, they questioned if she had had sexual trauma, recommended she meet with a therapist for her pain issues. And they offered her an antidepressant. They offered her oral contraceptives again. This is a second or third time. She accepted them at this time. They also recommended tramadol, and they started her on that. So she is going up and up with the different medications that she's using. And she was getting increasingly depressed and felt like there was something really wrong with her, and wondered, how do other people manage all these normal symptoms, and why do I have such a hard time? We're going to forward again to age 24, when she moves to the city that she's always wanted to live in. She's full of hope, and she has been starting to feel more chronic fatigue, often during her period, but at odd times during the month. And she's also suffering from painful bowel movements during her period. So she finds a new GYN, and this gynecologist sort of told her again that this was all within normal limits. They offered her an antidepressant again, and this time she accepted. And they also added Cymbalta to her pain regimen. She really felt crazy and started seeing a therapist to work on alienation from her own body issues. 2 more years later, she fell deeply in love. And intercourse was always painful, despite lubrication changes, position changes, but she was determined not to let this get in the way of her happiness. And 2 more years later, they got married, and she was determined to put the suffering behind her. But unfortunately, that wasn't what was going to come for her. The SSRIs had dampened her libido. She had scars all over her abdomen from incessant hot water bottle use. She was on a lot of different pain medications. They started down the long road of trying to get pregnant, and after a year and a half of tracking her cycles and her temperature, no pregnancy ensued, so she went to see a new OBGYN. And this was the beginning of her diagnosis and long road of treatment for endometriosis. She was scheduled and went to have a laparoscopy where they were going to see what they found and manage what they found. They came to her in the post-operative recovery room and told her that her abdomen and pelvic organs were riddled with endometriosis, including her appendix. They told her that they had removed one tube because it was so riddled with endometriosis, and they had barely saved the other and had little hope for her fertility. She was angry, despondent. How could things have gone on for so long? Why did no one believe me? Why does no one care? A year later, she had an ablation, and then she started on opioids and fell into a depression. Her marriage fell apart after a year. And the saddest part about this story is that it's not at all unique. And you will hear that later today. That this is a really common experience for endometriosis sufferers. And today, in my talk, I'm going to speak of women, and by women, I just mean anybody who's born with a uterus. And the term misogyny, as I refer to it, literally means hate women misogyny. And generally, it's a prejudice or ingrained discrimination against women. We're going to start by talking a little bit about the history of misogyny in medicine that started with Hippocrates in 400 BCE, followed by Aristotle in 360 BCE, where he characterized women as mutilated men. In some of the earliest medical sketches, all done by men, women were depicted having much smaller brains. And physicians of the day, who were also men, said that women were too high-strung to get an education and that their ovaries would become inflamed if they read too much. Hysteria, or excessive emotions, was first described in the second millennial BCE and was thought to be caused by having a uterus. This links perfectly with the current trope of the attention-seeking hypochondriac woman. In women's health concerns are often minimized or dismissed. They are less likely to be given painkillers than men for the same pain scale. They have to wait longer to receive pain management in the ER. And in several key areas such as cardiac care and pain management, women get different treatments leading to poorer outcomes. This situation is much worse among Black women. Historically, all of the human and animal subject studies have been male. In 1991, the first woman head of the NIH, Bernadine Healy, said, "We literally know less about every aspect of the female biology compared to the male biology. Diseases that affect women are largely a mystery, understudied, undertreated, and frequently misdiagnosed or undiagnosed." Historically, medical and medication studies have excluded women. The research data collected from men has been generalized to women, and this continues today. In the 1960s, they became aware that premenopausal women had less heart disease rates than postmenopausal women. So there was a study undertaken where they were going to see if adding estrogen was a therapeutic effective treatment. This study enrolled 8,340 participants, all of whom were men. A couple years later, the NIH was looking at how obesity affected breast and uterine cancer. And again, this study didn't enroll a single female. Women were not required to be included in clinical research in the US until 1993, and it wasn't until 2016 that the NIH mandated that any preclinical studies use research dollars to include female animals. Providers who practice pelvic medicine receive fewer payments from insurance companies, and when they do receive them, they're at a lower rate. Female physicians earn about $2 million less over the course of a 40-year career than male physicians. In medical academia, women are less likely to receive professorships and leadership positions. And a Canadian study showed that female patients were more likely to die when operated on by a male surgeon as opposed to a female surgeon. Public awareness is growing around the way that women are dismissed and misdiagnosed with article titles such as, "Why Don't Doctors Believe Women?" and "Doctors Are Failing Women with Chronic Pain." And doctors are more likely to misdiagnose women than men. To this day, women are diagnosed on an average of 4 years later than men across more than 700 diseases. I'm going to talk a little bit about endometriosis, which was described in Western medical literature over 120 years ago. It affects about 10 million women 10% of reproductive age women, which is about 4 million women worldwide, and accounts for tremendous suffering, mostly due to the the dysmenorrhea, dysuria. About half of all dyspareunia or painful intercourse is thought to be related to endometriosis. And 30 to 50% of infertility is thought to be related to endometriosis, and about 50 to 80% of chronic pelvic pain is thought to be related to that. As in the story, it often takes much more than 12 years of actively seeking a diagnosis in order for the diagnosis of endometriosis to be arrived at. The clinical hallmark of endo is diffuse, poorly marginalized pain. The true hallmark is suffering from the psychological distress, days work loss, fertility loss, chronic pain, pain with intercourse, self-esteem issues, relationship issues. Endometriosis is essentially the lining of the uterus. The endometrium migrates, we're not sure how, out of the uterus and onto other organs, mostly in the pelvis, but all can be anywhere in the body. And every month when women have their period, when they're bleeding from their uterus, there's an exit route through the cervix and eventually through the vagina. When women bleed into their abdomen or their pelvis, it's a closed system. And so it's pain, inflammation, adhesions, and scar tissue is formed. Treatments are the same that they've been for decades, and they are subpar. Pain medication, often including opioids and all the others that I mentioned in Jane's case. Hormonal contraception is pretty much the mainstay. Sometimes people are recommended pregnancy, even if they don't want children, to manage their endometriosis, and then surgery, which often has a lot of the lesions end up growing back. There is no agreed upon cause, and there is no known cure. We're going to look a little bit into how cannabis can help in this situation and harness this. Historical writings from all over the world, literally throughout time, have showed that cannabis is very helpful with symptoms consistent with endometriosis. The ECS, or the endocannabinoid system, is involved in both the formation, growth, or proliferation of endometrial tissue and the pain associated with it. Both of these can be improved with the use of cannabis. In the late 19th century, there was, in the US, there was a cannabis tincture that also had capsaicin, which makes us think about the vanilloid receptors. And it was used very, very effectively for menstrual cramps, and many households had that in their medicine cabinet. In terms of clinical endocannabinoid deficiency, this is a theory postulated by Ethan Russo, first in 2001, refined in 2004, in 2016, and again in 2020. And he believes that endometriosis is one of the clinical endocannabinoid deficiency, or CED, diseases or syndromes. The theory is that all humans have an underlying endocannabinoid tone, which is a reflection of the endocannabinoids in the state of their receptors, and that certain chronic, difficult to treat, impossible to cure conditions are thought to be caused by a dysregulated endocannabinoid tone. A cardinal feature of CED is an overlap with other comorbid CED diagnoses. We know that nearly 95% of endometriosis sufferers report at least one concurrent CED diagnosis, such as migraines, IBS, fibromyalgia, and chronic fatigue. How could cannabis help this particular patient? We know that cannabis as a self-titrated medicine gives agency back to the patient and takes it out of the hands of the medical establishment that has brutalized them. Mounting scientific information speaks to the link between cannabinoids and endometriosis. And endometriosis lesions have fewer CB1 and CB2 receptors, which decreases the normal apoptosis or programmed cell death, which allows the cells to multiply and spread. There is growing consensus in the current literature that cannabinoids have an anti-proliferative effect on endometriosis. And we also know that the ECS is involved with pain establishment in endometriosis, and that endometriosis lesions form their own nerve endings and thus cause increased pain. We know in real-world evidence, there's an Australian study that was composed of 484 patients, all with a confirmed diagnosis of endometriosis. And they reported that the most effective treatment of their own care for their endometriosis pain was cannabis, or is cannabis. We know that cannabis is a really good pain medication with a low side effect profile, especially at a balanced 1-to-1 ratio. And there are lots of clinical studies that are showing this to be the gold standard for pain management. And we know that suppositories can be really, really helpful, both vaginal and rectal, in endometriosis sufferers. And we also know that, that women find topicals, often CBD dominant, applied abdominally, to be really helpful. It will be at least a decade before there is robust clinical data to support the use of cannabis to decrease the huge burden of endometriosis in our sisters worldwide. As we know, it will likely be a decade or more after that before this overwhelmingly safe botanical compound makes its way back to its rightful place in our pharmacopoeia. Thank you. We are now